Dear students, we'll quickly revise some of the important topics in general consideration of antimicrobial therapy. So these are the classification of antimicrobial agents according to their mechanism of action. So the antibiotics which act by inhibiting cell wall synthesis or penicillins, cephalosporins, cycloserine, vancomycin, bacitracin, and those which cause leakage from cell membranes or polypeptides like polymyxins, colistin, bacitracin, and polyenes like amphotericin B, nystatin, harmycin, and those which inhibit protein synthesis or tetracyclines, chloramphenicol, erythromycin, clindamycin, linezolid, and antimicrobial agents which cause misreading of mRNA code and affect the permeability or aminoglycosides like streptomycin, gentamicin, and those which inhibit DNA gyrase or fluoroquinolones, those which interfere with DNA function or rifampicin, and those which interfere with DNA synthesis or antiviral agents like acyclovir, zirobidin, and those agents which interfere with intermediary metabolisms, like folic acid synthesis. So they are sulfonamides, sulfones, para-aminosalicylic acid, trimethoprim, pyrimethamine, and metronidazole. Drug resistance is an important topic under general consideration. Drug resistance means unresponsiveness of a microorganism to an antimicrobial agent. So the resistance can be natural or acquired. So acquired resistance is of greater clinical importance, and the acquired resistance can be due to mutation or gene transfer, and gene transfer again can happen through conjugation, transduction, or transformation. So the resistance organisms becomes either drug tolerant, for example, altered penicillin binding protein by pneumococci, or it can be drug destroying, for example, staphylococci producing beta lactamases which destroys the beta lactam antibiotics, and drug impermeable, for example, gram negative bacteria lost the porins which aids in the action of antibacterial agents like aminoglycosides. Drug resistance can be prevented by following these measures. The indiscriminate and inadequate or unduly prolonged use of antimicrobial agents should be avoided, and rapidly acting and selective narrow spectrum antimicrobial agents should be preferred as far as possible. Combination of antimicrobial agents should be used whenever prolonged therapy is undertaken. The next important topic is superinfection. Superinfection means appearance of a new infection as a result of antimicrobial therapy. So the reasons behind this appearance of superinfection are usually the normal flora contributes to host defense by elaborating substances called bacteriocins. So this antimicrobial therapy is going to reduce this normal flora. So it's not only destroys the pathogenic organisms but also destroys your normal flora. So this protective effect of normal flora is going to be reduced, and also usually the normal flora competes with the pathogenic organisms for nutrition. So your antimicrobial therapy is going to reduce this competition also. So commonly associated antibiotics which are more prone to cause superinfections or tetracyclines, chloramphenicol, ampicillin, and cephalosporins. So the most common sites involved with superinfection are usually those sites which normally harbor commensals like your oropharynx, intestinal, respiratory, and genitourinary tracts. The most common organisms involved in superinfection are Candida, Clostridium difficile, Proteus, Pseudomonas, and resistant staphylococci. So Candida is usually causes vulvovaginitis, oral thrush, and you are going to use antifungal agents for candidal infection. And Clostridium difficile, it causes pseudomembranous colitis which produces diarrhea, and metronidazole and vancomycin are used for the management of Clostridium difficile infection. And Proteus may cause urinary tract infections, and Pseudomonas resistant staphylococci, so all they are all going to be treated with cephalosporins which are sensitive to pseudomonal infections and resistant staphylococci. The conditions predisposing to superinfections or when the host defense mechanisms is already compromised, like when the patient is in corticosteroid therapy, or the patient has leukemias and other malignancies, AIDS, agranulocytosis, diabetes, disseminated lupus erythematosus. These are all the predisposing factors or conditions for superinfections. So how can we minimize superinfections? The use of specific narrow spectrum antimicrobial agents whenever possible, and not using antimicrobials for very trivial self-limiting or viral infections, and not unnecessarily prolonging antimicrobial therapy. And these are the other important terminologies you must know. Minimum inhibitory concentration, MIC. So this is the lowest concentration of an antibiotic which prevents visible growth of a bacterium after 24 hours incubation in microbial culture plates using serial dilution of the antibiotic. So this MIC is actually derived in the lab. Okay, so when they grow the culture with the antibiotic, so the lowest concentration which prevents the visible growth of the bacterium, so that is the minimum inhibitory concentration. And minimum bactericidal concentration, MBC, so this is the concentration of the antibiotic which kills 99.9% of the bacteria. So here it kills the concentration which actually kills the bacteria, so that is the minimum bactericidal concentration. Post-antibiotic effect. So this means the lag period in growth resumption after exposure to antibiotic is known as post-antibiotic effect. So usually the inhibitory action or the antibacterial or antimicrobial action, it lasts as long as the therapeutic plasma level is there. But even after the therapeutic concentration of antimicrobial agent falls down, still there is some time period, there is some lag period, after which again the bacteria starts to grow. So this lag period is known as the post antibiotic effect. So this is the time required for reattainment of the logarithmic growth of the microbial agents. So it is actually calculated from the time required to attain tenfold increase in the bacterial count in the culture for antibiotics exposed and unexposed tubes. So the antibiotics which shows the post-antibiotic effect are fluoroquinolones, aminoglycosides, and rifampicin. And these are the other two important pharmacokinetic concepts of antimicrobial agents. So concentration dependent inhibition. So this means inhibitory effect of the antimicrobial agent depends on the ratio of the peak concentration to the minimum inhibitory concentration. So that means the maximum inhibitory effect is shown when the concentration, the plasma concentration of the antimicrobial agents is at its peak. Okay, so the antimicrobial agents which shows this concentration dependent inhibition or aminoglycosides, fluoroquinolones, and metronidazole. So the when you give an aminoglycoside like gentamicin, the daily dose of gentamicin produces better action when given as a single dose, because see, suppose if you are giving gentamicin as a BD dose, so instead of this BD dose, if you give it as a single dose, the peak concentration increases. Okay, so this shows maximum inhibitory effect because it shows concentration dependent inhibition. Okay, and similarly there is another concept called time dependent inhibition. So this means the antimicrobial action depends on the length of time the concentration remains above the MIC. So here it doesn't depends on the peak concentration, but rather depends on the length of time it remains above the MIC. Okay, so for those antibacterial, antimicrobial agents which shows time dependent inhibition, the dose has to be divided and given. Okay, so that the it remains above the MIC over a prolonged period of time. So the antimicrobial agents which shows time dependent inhibition or beta lactam antibiotics, glycopeptides, and macrolides. So these antibiotic has to be given in many divided doses, okay, in order to achieve better therapeutic efficacy.